Here's a challenge. By the end of this lesson, you should be able to draw this entire pathway exactly as we covered it and explain every step from start to finish. If you can do that, you've mastered the core. For the next few minutes, we focus only on that core. Nothing extra, nothing unnecessary. Everything else is noise. Let's begin. Alright, today we are going to review the four main types of shock. Shock basically means a failure of saturation, and clinically, we often see a combination of hypertension, tachycardia, and altered mental status. Before we begin, let's remember a simple rule. Blood pressure equals cardiac output times systemic vascular resistance. How much blood the heart pumps out and how tightly the vessels are constricted determines the blood pressure. Keep this basic idea in mind as we go through the explanation. First, let's review our normal hemodynamics. Here we have the heart. Blood flow into the arteries, pass through capillaries, and returns through the vein. This cycle repeats continuously and keeps our circulation stable. However, even small disruption to this repeating cycle can cause the entire system to collapse. For example, suppose the heart pumps 10 and 10 returns. If 2 escape from the saturation, like hypovolemia, only 8 returns. Next cycle, 8 goes out, 2 leaks again, and 6 returns. This repeating loss gradually lowers blood pressure and leads to shock. Next, let's clarify shock into 4 major types. Shock can be categorized into cardiogenic shock, distributive shock, obstructive shock, hypovolemic shock. Let's break them down one by one. As I explained, this occurs when circulating volume is lost. So, bleeding is a classic cause, but burns, heat stroke, pancreatitis, and massive diarrhea can also lead to significant dehydration and shock. Treatment includes fluid resuscitation and blood transfusion and surgical control of bleeding. In the cardiogenic shock, here the heart cannot generate enough pressure to eject blood effectively. Common causes include myocardial infarction, tachyarrhythmia, and bradyarrhythmia. Clinically, cardiogenic shock often presents with cold, clammy extremities, and pulmonary congestion due to elevated filling pressures. Treatment depends on the cause: catheter intervention or surgery for MI, defibrillation, antiarrhythmics for tachycardia, and pacing for bradyarrhythmic shock. Next, let's move on to distributive shock. This shock occurs when microcirculatory duration or leakage causes blood to pool in the periphery, reducing venous return, like in hypovolemia. Heart pumps out 10 and 2 escapes from circulation into the new pool, only 8 return. Typical causes include sepsis, anaphylaxis, and neurogenic shock from spinal cord injury above T4. A key clinical point: distributive shock often begins as warm shock with warm hands and feet, and may progress to cold shock in late stage as cardiac output falls. Among the causes of distributive shock, septic shock is by far the most common in real clinical practice and is also heavily tested on exams. So let's take a moment to look at it a little more deeply. Septic shock is often caused by gram-negative rods. The wall component LPS is recognized by neutrophil and macrophage, which release cytokines like TNF, interleukin 1. This includes capillary permeability. LPS also injures endothelial cell and includes nitric oxide, a powerful vasodilator. The result, vasodilation and pooling, leading to decreased venous return and hypotension. Treatment includes norepinephrine, early antibiotics, and source control. For anaphylaxis, epinephrine is essential. Finally, let's look at obstructive shock. Here, blood cannot return to the heart because the door for venous return is blocked. Common causes include tension pneumothorax, cardiac tamponade, and pulmonary embolism. In massive PE, right ventricular pressure becomes so high that blood cannot return, causing obstructive shock. Treatment includes needle decompression, drainage for pneumothorax or tamponade, and anticoagulation or thrombolysis for PE, with surgery in severe cases. Regardless of the causes, The first step in shock management are the same. Secure the airway, provide oxygen, establish IV access, and start breathe unless contraindicate. Cardiogenic and obstructive shock may need more careful fluid management, but the approach always comes first. These are the essential clinical features of shock. This is a shock quick clinical checklist. Remember, this lecture is for educational purposes. In actual clinical settings, always respond flexibly to each patient's condition. Stay calm and act first.